Welcome to the Deep Dive, where we take your pilot information and distill it into the crucial nuggets you need to know. Today we're embarking on, well, a fascinating journey, but also a challenging one, into equine health. We are tackling a really complex condition. It's called Eosinophilic Enteritis, or EE in horses. You've given us a stack of quite comprehensive sources, really diving deep into its forms, diagnosis, and treatment. Our mission today, to cut through the jargon, clarify what makes this disease such a tricky puzzle, and really highlight what stands out from all this material. We're basically aiming to be your guides through this medical detective story. Okay, let's unpack this.
Indeed. Yeah, eosinophilic enteritis, it's a type of inflammatory bowel disease in horses. And it's a condition that, well, it can manifest in surprisingly diverse ways. That makes it quite the diagnostic challenge and a therapeutic one, too, for vets. We'll be looking at how an abnormal immune response, specifically involving these white blood cells called eosinophils, can cause pretty significant issues in a horse's digestive system. And sometimes, it goes far beyond just the gut.
So to start our investigation then, what exactly is eosinophilic enteritis? And what are these eosinophils actually doing in a horse's gut that causes so much trouble?
Okay, so at its most fundamental level, EE is characterized by an abnormal infiltration. It's almost like an invasion, really. An invasion of eosinophils into the wall of the small intestine. Now, these eosinophils, they're a type of white blood cell normally involved in things like allergic reactions and defending against parasites. But in EE, they're just accumulating where they shouldn't be and in numbers they shouldn't be. And that causes inflammation. This infiltration, it can also extend to the large intestine. We call that eosinophilic colitis, or it can affect both, which is known as enterocolitis. Now, what's truly profound from our sources, and frankly, it's still a bit of a medical mystery, is that the root cause, it remains largely unknown. It's deemed idiopathic. And this isn't just a small detail. It fundamentally impacts how challenging the diagnosis and treatment can be.
Yeah.
Because you're often chasing symptoms without knowing that definite underlying trigger. The body's just reacting inappropriately. Maybe to dietary antigens or parasites or, other environmental factors. We just don't know for sure.
So it's like the horse's own immune system is kind of overreacting and attacking itself.
Exactly.
That sounds incredibly complicated already, especially if we don't even know why it starts. As we started diving into these sources, one thing that became clear quite quickly was how distinct these three forms of EE are, but sometimes interconnected too. It seems like a really critical part of understanding this disease. Can we walk through these different presentations?
Absolutely. Yeah, understanding these forms is crucial. They really dictate the clinical picture a vet sees, and they significantly influence the prognosis too.
Okay, let's start with the first one. Diffuse eosinophilic enteritis, or DEE. What are the hallmarks of this form? What should someone be looking for?
So DEE involves this widespread eosinophilic infiltration throughout the small intestine. It mainly affects the surface lining and the layer just beneath it, the submucosa. It often presents like a chronic condition, something persistent. So think of a horse that's just, not thriving. Chronic weight loss, even though it's eating well. Recurrent low-grade colic, maybe just seeming a bit uncomfortable sometimes, not necessarily rolling in agony. Sometimes intermittent diarrhea, and other signs like, depression or just a dull hair coat. The core issue here is malabsorption and maldigestion. The damaged gut just can't properly absorb nutrients.
Okay. Then there's the second form, idiopathic focal eosinophilic enteritis, or IFE. This one sounds like it could be more of a sudden acute crisis.
It definitely can be. IFE is typically more acute and often more severe. It's described as a discrete thickening, often like a band, in just one segment of the small intestine. And this thickening can dramatically narrow the intestinal passage, the lumen, leading to a partial or even a complete blockage of feed flow. The inflammation in IFE tends to be deeper, too, affecting the muscle layers of the intestinal wall. That's why it can cause such severe blockages.
Wow.
And what really stands out about IFE is its typical presentation. Acute, severe, often recurrent colic. And it's often seen in younger horses, usually between, say, birth and 5 years old.
Younger horses, interesting.
Yeah. And these cases frequently end up needing surgical intervention because of that obstruction.
Yeah.
It's also interesting. While it's relatively rare overall, our sources do point to it being more frequent in certain geographic regions, parts of the USA, Ireland, the UK. And apparently there's been a subjective increase in prevalence in the Northwest UK over the last 10, 15 years.
Huh. Any idea why?
That geographic clustering is a fascinating piece of the puzzle, but the sources don't definitively say why. Could be environmental, genetic, we don't know.
And didn't the sources suggest a potential link between these two forms? That IFHE might actually be like a focal, intense flare-up of an underlying diffuse issue?
Precisely. That's a key insight. Histology, looking at tissue samples under the microscope from seemingly normal areas in IFFE cases often reveals that underlying diffuse eosinophilic infiltration. So yeah, it strongly suggests IFE is a focal manifestation in horses that already have underlying DEE.
That's fascinating. Okay, and then the third form, multisystemic eosinophilic epitheliotrophic disease, or MEAD. Just the name alone sounds incredibly serious and, well, widespread.
It is. It's the most generalized and unfortunately the most severe form. In mead, the eosinophilic infiltration isn't confined to the GI tract. It's kind of gone rogue throughout the body, attacking other organ systems too.
No.
Yeah, this can include the skin, leading to really severe dermatitis, especially on the face, limbs, the belly, but also the liver, pancreas, lungs, even the inside of the mouth and the lymph nodes.
So it's truly systemic.
Absolutely.
Oh.
And its clinical presentation is highly variable because it depends on which organs are affected. But chronic weight loss and recurrent colic are still common, alongside those really severe skin lesions. The histological lesions are distinct too, often involving things called eosinophilic granulomas, almost like little inflammatory masses, and vasculitis, which is inflammation of the blood vessels themselves.
Goodness.
It really shows how widespread and, frankly, destructive this form can be. So with such a wide range of symptoms across these forms, how do vets even begin to differentiate them? How do they arrive at a diagnosis?
Yeah, diagnosing E really sounds like putting together a very complicated puzzle, especially since, as you said, many of the signs aren't very specific. What are the key pieces of evidence in this diagnostic detective story?
It can be incredibly challenging, you're right. The first crucial steps involve a really thorough look at the clinical signs and the history the owner provides. As we discussed, recurrent colic is a common thread, though that acute severe colic points more strongly towards IFE.
Right.
Weight loss, despite a good appetite, that's a big red flag, suggests malabsorption, especially for DAE or MEAD. Diarrhea is variable, depends if the large intestine is involved. And then other clues. Poor performance, maybe lethargy, or those specific systemic signs like the skin lesions or respiratory issues, those really strongly point towards MEAD.
Okay. And what about just a physical exam? Can that offer much insight when so many of the problems seem internal?
Well, sometimes a physical exam can actually be pretty unremarkable, especially in milder cases. But in more chronic situations, yeah, you might see signs of dehydration, poor body condition, maybe that dull, unhealthy hair coat. And in acute colic cases, you might notice the abdomen is distended or the gut sounds are altered, things like that.
So the clinical signs are the first clues. Physical exam maybe gives a bit more context, but often isn't definitive. Where do you go next for more concrete evidence? Does this mean needing to dig deeper into lab work, perhaps, to see what's happening inside?
Exactly. The next layer of this diagnostic deep dive is the lab work. Blood tests, other samples. Now, they're not always definitive on their own, but they provide absolutely crucial pieces of the puzzle, and they help rule out other conditions too. We're looking for a few key things, mainly. First, signs of inflammation. A complete blood count, a CBC, might show an elevated number of those eosinophils in the blood eosinophilia.
Oh, okay.
But while it's suggestive, it's not always present, especially if the disease is localized, like just in one spot.
Yeah.
And it's not specific to either parasites or other allergies can cause it. It does seem to be more common with MEAD, the severe systemic form. Second, we look for protein loss. Serum biochemistry often reveals low serum albumin. That's called hypoalbuminemia. This is a really common indicator of what we call protein-losing enteropathy. Basically, the damaged gut wall is actually leaking essential proteins out of the body.
Oh, that sounds bad.
It is. It can lead to serious complications, further weakens the horse. You might also see high globulins indicating chronic inflammation, and with MEAD, liver or pancreatic enzymes might be up. Third, absorption problems. There are specific tests like the oral glucose or D-xylose absorption test. These check how well the small intestine is actually absorbing nutrients. If you get a flat or blunted curve, meaning the blood sugar or xylose doesn't rise much after you give it orally, that clearly indicates malabsorption. It supports a diagnosis of a diffuse gut problem.
Okay, so that confirms the gut isn't working properly.
Exactly. And finally, fluid analysis. In severe cases, especially IFE with potential obstruction, doing a belly tap abdominocentesis can be revealing. You might find elevated protein levels or an increased cell count in that abdominal fluid, often with a high proportion of eosinophils. That confirms severe inflammation or obstruction.
So those tests definitely point you in the right direction, give you important clues, but still maybe not the final answer. What about imaging? Can things like ultrasound help see what's going on?
Yes, diagnostic imaging is very helpful for actually visualizing the gut. An abdominal ultrasound is key here. It can reveal thickening of the intestinal wall, either focally in one spot or diffusely spread out. Sometimes you lose that normal layered appearance you expect to see. In IFE specifically, you might see those dilated, fluid-filled loops of small intestine building up before the site of an obstruction.
Ah, you can actually see the backup.
Precisely. You might also see enlarged mesenteric lymph nodes. Radiography, like X-rays, is less useful for the diffuse changes, but it can show gas and fluid patterns that suggest an obstruction in IFE cases.
Okay, so after all that incredible detective work, the history, the exam, the labs, the imaging, what gives you the absolute definitive diagnosis, the confirmation?
Right, the gold standard. The most definitive method for diagnosis is getting biopsies for histopathological confirmation, looking at the tissue itself.
Biopsies. Okay. How do you get those?
Well, there are a few ways. Rectal biopsies are the least invasive, but honestly, they're often not representative of what's happening higher up in the small intestine, though they can be useful for mead if those specific granulomas happen to be present there. Then there's gastroduodenoscopy with biopsy. That involves passing a scope down into the stomach and the first part of the small intestine to take small pinch biopsies. Less invasive than full surgery.
But maybe still not getting the full picture.
Potentially not, especially if the lesions are deeper or further down. Which leads us to the surgical biopsy, usually done via exploratory laparotomy abdominal surgery. This is described in the sources as the most definitive method. It allows you to get full-thickness biopsies of the affected intestine. It's often done when a horse needs surgery anyway for severe colic, especially with IFE, or maybe when other diagnostics just haven't given a clear answer.
Right, if you're already in there surgically.
Exactly. It lets the vet directly inspect the bowel, choose the best sites for biopsy, and crucially, in IFE cases, they can even perform resection, remove the affected segment right then and there. It's really the only way to definitively confirm the cause of that small intestinal obstruction in IFE and rule out other possibilities. And like we said, sometimes they find just one lesion, sometimes, believe it or not, over 40 separate lesions in one horse.
40. Wow. Okay, so once you have that definitive diagnosis, what's the general approach to treatment? It sounds like, given the complexity, there's no single magic bullet.
You're absolutely right. There isn't one simple cure. Treatment for eosinophilic enteritis is largely symptomatic. It focuses on reducing that runaway inflammation, trying to improve the absorption of nutrients, and of course managing any pain associated with it, especially colic.
So what's the main medicinal approach then? What drugs are typically used?
The cornerstone of medical treatment is corticosteroids. Drugs like prednisolone or dexamethasone, these are powerful anti-inflammatory medications. Their job is to suppress that eosinophilic infiltration and the inflammation it's causing. Typically, they're started at quite high doses to try and get the disease under control, induce remission, and then they're gradually tapered down over weeks, sometimes months, to find the lowest effective dose.
Okay.
Usually given by injection, IV or IM, initially, especially if the horse is quite sick, then switch to oral medication for longer-term management.
Are there risks with using steroids long-term?
Oh, absolutely. Careful monitoring for side effects is crucial. Things like laminitis, that really painful hoof condition, immunosuppression, making them more vulnerable to infections, and gastric ulcers, these are real concerns. And while some cases respond very well, other horses can be quite resistant or refractory to treatment. Ongoing medication might be needed for a long time, particularly for DEE, the diffuse form, because relapses are pretty common if you stop the medication too quickly.
Right, so it's a balancing act. What about managing their diet? That must be tricky for horses, given they're designed to eat forage most of the time.
Yes, dietary management is definitely very important and challenging. The general recommendation is small, frequent meals of easily digestible, low-antigen feed. Trying to identify and eliminate potential dietary allergens is tough in horses, much harder than in dogs or cats. But some vets do try maybe switching to a novel protein source or a specific hypoallergenic diet, sometimes just a single type of forage and a very restricted concentrate. Supplements like probiotics, prebiotics, maybe omega-3 fatty acids might also be considered to support overall gut health, but the evidence for their effectiveness, specifically in EE, is still developing.
And what about deworming? You mentioned parasites earlier. Even if you don't find evidence of active parasites, is that still part of the plan?
Yes, that's a really key point. Even though we call EE idiopathic, meaning unknown cause, we know eosinophils are involved in parasite reactions. There's a strong suspicion that past parasite migration or an abnormal reaction to parasites could be involved somehow.
Ah, okay.
So even if routine fecal egg counts are negative, which often just detect adult egg-laying worms anyway, a thorough deworming program is often recommended, specifically using drugs that are effective against migrating larvae, not just adults. It's often done as a sort of diagnostic/therapeutic trial.
Kind of a better safe than sorry approach.
Exactly. Given the immune system's role and the link with the eosinophils, it makes sense to rule out or treat any potential parasitic trigger.
Okay. Now, you mentioned surgery earlier for IEF, especially for those acute obstruction cases. How does that fit into the overall treatment picture?
Right, for horses with IFE, that's causing an intestinal obstruction. Surgical resection, meaning removing the affected, narrowed segment of the small intestine, can actually be curative for the obstruction itself.
Curative, that sounds promising.
For the obstruction, yes. It's often performed during that exploratory laparotomy we talked about, which allows the vet to confirm the diagnosis and also decompress the backed up small intestine. Now, this is an interesting point where our sources maybe offer slightly differing perspectives or nuances. Some suggest that even after removing the focal lesion, horses might still need ongoing medical management, like steroids, because of that potential underlying diffuse disease, the DEE.
Right, because the focal bit might just be the tip of the iceberg.
Potentially. However, other sources specifically mention that IFE lesions seem to resolve quite quickly, like within 3-7 days after surgery. And importantly, recurrence of those focal lesions hasn't really been documented. So because of that, and to avoid impairing the healing of the surgical incision with steroids, ongoing steroid therapy isn't normally recommended right after IFE surgery.
I see. So it depends on the specific case and the vet's assessment.
Precisely. It highlights the need for careful individual assessment.
And what about just general supportive care throughout all of this, regardless of the form or treatment?
Supportive care is absolutely vital. It includes things like intravenous fluid therapy if the horse is dehydrated, using NSAIDs like Flunix and Meglumin for pain relief during colic episodes. In really severe cases with significant protein loss, plasma transfusions might be needed to boost their protein levels.
Plasma, wow.
Yes, and prophylactic laminitis care preventative measures if there's severe inflammation, because that's always a risk with sick horses, especially those on steroids. For acute IFE cases specifically, IV fluids are critical, pain relief, and often antimicrobials post-surgery to prevent infection. Sometimes drugs to help gut motility too.
Okay, so bringing it all together, how does this ultimately play out for a horse diagnosed with E? Is there a good outcome possible, or is it always a long, tough road ahead? What's the prognosis?
Well, the prognosis varies significantly. It really depends on the specific form of EE, how severe it is, and crucially, how well the individual horse responds to treatment. For diffuse eosinophilic enteritis, DEE, the prognosis is generally described as guarded to fair. Many horses can be managed medically with corticosteroids and careful diet changes, but it often requires long-term therapy.
Right, you mentioned relapses are common.
Exactly. Relapses are common if medication is withdrawn or even just taper too quickly. Some horses may never fully regain ideal body condition, and their prognosis for long-term athletic use is often guarded as well.
Okay. What about idiopathic focal eosinophilic enteritis, IFE, the one needing surgery?
For IFE, the prognosis is generally considered fair to good with surgical intervention. If the diagnosis is made early and the affected segment can be successfully removed before irreversible damage occurs, then surgically removing that focal obstruction can resolve the acute colic signs. Long-term survival rates can actually be quite high. The sources mention up to 100% in some studies, provided there aren't major complications early after surgery.
That's definitely a point of optimism, then.
It is. Surgery can be very successful for resolving that specific blockage issue in IFE.
But then there's multisystemic eosinophilic epitheliotropic disease, MEAD. You said earlier it was most severe.
Unfortunately, yes. For MEAD, the prognosis is poor. Because it involves so many organ systems, the response to treatment is often very limited. Long-term survival is low, and sadly, euthanasia is frequently considered due to the horse's poor quality of life. The sources really highlight this for MEAD. Despite all best efforts, the prognosis is often grim. It's a stark reminder of the limits of our current understanding and treatments for these complex immune diseases.
So it really is a broad spectrum then, from potentially manageable with careful long-term oversight to incredibly severe and challenging.
Exactly. Eosinophilic enteritis, in most forms, is typically a chronic condition, often lifelong. Response to treatment varies hugely between individuals. Long-term management can be expensive, definitely demanding for the owner, and recurrences are common. It just really highlights the importance of getting that thorough diagnostic workup done. Having a committed owner who understands the long haul and developing a tailored treatment plan that will almost certainly need to evolve over time.
Wow, what a journey into the complexities of equine health. It really is intricate. From that subtle chronic weight loss you see with DEE to the acute surgical emergency of IFE and then the widespread severity of MEAD, it's crystal clear that eosinophilic enteritis is far from a simple diagnosis or treatment. It truly sounds like a masterclass in veterinary detective work.
Absolutely. Understanding these distinctions, the different forms, and that multifaceted diagnostic process is just so key. It's key for anyone involved in equine care, vets, owners, technicians, or even just someone curious about veterinary medicine. The ability to identify these different presentations and to know when a horse needs that immediate surgical help versus potentially years of medical management, it really underscores the critical thinking and the nuanced understanding required in these cases.
Absolutely. So what does this all mean for you listening in?
Well, I think it's a powerful reminder of just how intricate the body's immune responses can be, even in our animal companions, and how much dedication, knowledge, and real detective work goes into solving these complex medical mysteries. Thank you for joining us for this deep dive today. We really hope you feel a little more well-informed and maybe, hopefully, a lot more curious about this fascinating world of veterinary diagnostics and treatment.
And maybe consider this. How might future advancements, particularly in understanding the immune system, finally unlock that idiopathic nature of conditions like EE? And what revolutionary, perhaps even preventative treatments might that understanding lead to down the road?